Happy Friday.
Yeah.
Okay, great. Welcome to the PCMH webinar on monitoring data and process improvement. My name is Mary Scones. I'm the lead for the TennCare PCMH program. And I want to kick it off by just introducing Rick Walker. Rick Walker is the coach lead and also a PCMH coach for Navigant. Rick has put together a presentation today to give you some helpful tips and information to support you in your practice transformation and quality improvement around performance management and also in patient-centered access and continuity. Those are some NCQA concepts that he's going to be walking through, as well as sharing some examples and some helpful tips for your practices to take back and use for your transformation. Before I kick it off with Rick, I also want to touch base on some housekeeping items. Everyone's line is currently muted, so if you have any questions or any comments, please enter those in the chat box on the side of your screen, and Christina will get that information over to the group or to Rick share. Also, I want to note that we will be recording this webinar as well as posting the slide deck to the PCMH webpage following the webinar for those of you who would like to reference it later, or if there were staff who were not able to attend today. And so with that, I will turn it over to Rick.
I appreciate that, and good evening to Middle and West Tennessee, and good afternoon to East Tennessee, and Friday. Hope you're having a great Friday so far. So Meredith talked about, here's our agenda for today. These are that we'll run through. In my slides, we'll jump back and forth between process measurement and improvement. There's a reason for that, but you'll see that as we go through here. And so, like you said, if you'd like to ask questions, make a comment, please put that in the chat box. And we have myself monitoring that, and Christina Rodich with Navigant monitoring that as well. And I just to give Christina props for putting this all together and making this happen. We couldn't do it without her. The concepts we'll be covering today, most QI aspect of it is really where we'll be hanging out though. And before I go any further, if you hadn't heard, NCQA has updated the 2017 PCH standards. We just got notification of that yesterday. If you get emails from NCQA, you should have received that. You go into your my.ncqa.org account and get to those. Your coach may send those out to you. Either way, just make sure now that we archive version 2 and we are into version 3. One of the nice changes that they made is that an additional 21 of the criteria can now be shared across all the clinical sites in your practices. So it is a big improvement, making things a lot easier for all of us in putting that information together. And then there's been an update to some of the language in each individual criteria just to provide better explanation and make sense. So I guess say on that yet, make sure you get that, contact your coach, and we'll go. So really where we'll be covering today, QI, we'll talk a little bit about that, but we discussed that in the webinar. So jump to QI1 here. Now, monitoring at least 5 clinical quality measures across 4 categories. This is a core requirement. Use practices delivering safe, effective, patient-centered, and timely care. So your practice show it monitors at least 5 measures, including 1 immunization measure, could be some of those examples up there. 1 preventative care measure, not including immunization measure. And just to let you know, a measure on oral health counts as a preventive clinical quality measure. So oral diseases and disorders in and of themselves, since they affect health and well-being, if that's something that you're monitoring, you can also. Or acute clinical measure. So there. One, the health measure. Data must include the report period. The data needs to include the measurement period, number of patients represented by the data, and rate and measure resource. For example, HEDIS, measure guidance, some to that effect. And I'm going to do something you probably shouldn't do in webinars, but I found an example that I want to show you, and I'm going to, if I can, bring over into my screen here. It may not. See, this gives me challenges. It's not working, sorry, but I will include it in the slide deck so you see it. But it's a nice example of what a report looks like for the criteria for this. That found at the last minute. I wanted to try to get that in there, but I already had the presentation up. So that's QI number 1. QI to monitor at least 2 measures of resource stewardship. Using choosingwisely.com to help you identify measures, for example, reducing MRI referrals for low back pain, if that's something that you can do. You see we have some examples there. One that most of my practices are using for measures affecting healthcare cost is prescribing generic medications versus brand name medications. And if you have a robust EMR system that also has a PCMH package or something of that sort involved in it, you'll be able to track it that way as well. Some opportunities, if you could think of anything else, please share those with folks. Or if you're using something else, please put that in the chat as well, and let us know what you may be using to meet this. Number UI3, assess performance on availability of major appointment types to meet patient needs and preferences. So patients who can't time limit, with their primary care provider may seek out-of-work care, which of course leads to potential higher cost and treatment from a provider who doesn't know their medical history. Consistently review the availability of your major appointment types. For example, patient routine follow-up, ensure that it's meeting the preferences or the way patients are accessing your care. Adjusting appointment availability is, if necessary. Measure one that many of you experience are changes. For example, and ready to go back to school, you probably see an increase in well visits as opposed to sick visits. But then we hit that October-November time period where people start getting sick, and you'll notice that you'll have an increase in the number of appointments that you have to utilize. But and keeping an eye on that is important. A common approach to measuring appointment availability against the standard is to determine the third next available appointment. And here's an example of that. This is in a practice did. Of course, the names have been changed to protect the innocent, but they looked at 5 different appointment types they had and when that third next available was for each provider. And see, they started 9th and looked out until they could that third appointment. And overall, really good access, as people and things of that nature. That's going to change somewhat, but you can look at this annually, semi-annually, quarterly. That's to you, but it depends on what access is looking like for you, making sure your patients are able to get in and see you in a timely manner, so they don't go those other routes of the ER or some other out-of-network provider. We talked in the last webinar about monitoring your patient experience through ways, making sure that you analyze the data so you can identify opportunities for them. And your suggestion box, focus groups, or individual interviews are required for the qualitative feedback. So not doing something like that, to implement that, and done for their virtual check-ins with NCQA is submit examples of the documents that have been completed by a patient. Put them into QPass prior to your virtual review, or and have them at the ready during your virtual review that you can be your reviewer. But you will ask to see some examples from patients. You may show that you use, but they're going to have some patient examples. And if you haven't implemented that yet, just keep in mind that for QA to accept any documentation for evidence, it has to be in place 90 days. So make sure your implementation dates on all documents as well. This is a credit assessing health disparities using data stratified for vulnerable populations. Those who are made vulnerable by their financial circumstances, their place of residence, their health, their age, any personal characteristics, that nature, chronic illnesses or disabilities. Some of the vulnerable populations that have in your practice. And I know it's sometimes difficult to find these disparities, even if you think they exist. It can be a challenge sometimes to find them. This area does require some work on your detective cap in some cases for this. And then some of you already know what this you've been dealing with it a number of years. You may not find a disparity that you thought was present. Sometimes even after 3 or 4 attempts, you might not find actual disparity. But I encourage you to keep pressing and looking for those things. And when you do find those, you have to choose from sections: quality and the patient experience. And it needs to be from what you use in QI1 through QI03. So HPV vaccine, colon cancer, screening type, for example. The thing with the patient experience, that goes with QI4, that your survey maybe includes some quite about vulnerability on there, and you can see some of the examples. How to select your criteria to monitor. Now we're going to talk about where we go from here. Driver to get us to go. So performance measurement. So after selecting the criteria to monitor, your next step is to get detailed. We get in to choose the measures that you want to or need to report. Before we do that, though, it's important to know that CMS has gone through the trouble of defining measures so that practices are evaluated fairly. Comparison applies to apples across practices, locally, really, and nationally. Here's a shot of electronic CQMs that you can find on the CMS website. If using a certified EHR, reports within your EHR have been validated by EMS. So on the slide, you can see the link to the site where you can determine whether your EHR is certified if you don't know already. Custom reports, track that manually if you want to monitor data that's not in a report from R. So the step is to decide on the specific measures that you want to report. You may want to pull reports from all quality measures before deciding what to work on. This is just a look at a reporting tool from one of the EMRs. Now, once you measure and run the report, the next step is to enter the data from the report into a spreadsheet. This is an example. I put it in the spreadsheet. This is a spreadsheet, of course, for the foundation of all dashboards, and we talked about dashboards at the last conference and one of the afternoon collaboratives. It's just more than a way to visualize the data. But yes, of course, numbers don't tell the whole story. You could search for trends and opportunities, but very time consuming. So how to make these numbers full? Dashboard, create one chart. This is a visual representation of the data that was entered on the previous spreadsheet. So about this back at the conference, why do we need a dashboard? Provide you a picture of how you're doing over time. A provider, how each one of them is doing, how the practice is doing as a whole. It tells a story. It's simple. On the slide, it tells the story of the practice that acted to improve on a measure and met their goal. The writing outcome is easy to see on this chart. And of course, we're going to have a positive outcome. I wouldn't show anything else. But buried in the numbers, this could all be buried in the numbers, though, on that previous spreadsheet. This is much easier to look at and get that quick glance. So the straight horizontal line on the graph represents the goal the fictional practice was working towards. And along the bottom of the chart shows the months in which the data was collected. Providers are listed in the key, and their individual data is shown as separate colored lines on the chart. And then the dotted line shows the results of the practice. Notice the bottom right-hand corner of the chart. It tells where the patient came from. This board tells the story of a practice who significantly increased the rate of their patients who receive mammograms. And goals earlier, benchmarks for measures can be found in a few places. Practice is part of an ACO, they have that. The MCOs have those on their reports. You may be able to get them from other reporting resources like UDS or Meaningful Use. Now, it sounds intimidating. We've got a dashboard template that we could and will be happy to share with you. I don't think I have to say this, but I will. The world of EHR reports is not perfect. Not all reports work as well as we would like them to. Compared here of cervical screenings, it's telling us that 164 patients, that not one of them received cervical cancer screening. Does it? It's probably not. I've found that most of the time when there's zeros, that right, usually there's some other underlying issue. Three things could be wrong. Your workflow may need some refinement. Just confused about where to document, or not be documenting in the exact field that the EHR report is getting data from, or it can be broken, and that's something you'd have to reach out to your first for. But it is with computer issues, the first thing you're supposed to do is if something doesn't work, you restart it. If that doesn't work, you check all your connections. Do all those things before you reach out to EMR. The things that you can do is confirm that your staff are following the workflow for those measures. They're looking at the patient records that should be capturing the data. You're verifying that. If they're being followed, reach out to some other folks using your EHR see if they're having any issues. And then again, you can always contact your pull data, enter into the spreadsheet, and most important, we talked about scrutinizing at that last port. So we're on the excelling data analysis. But once you have an opportunity to improve, next, let's talk about this improvement. And there are those other criteria and QI concept that we need to look at. Typically 8 through 11, those are core requirements. And those things, for example, in 12, we're going to get those credits as well. More criteria in here that we can, and that you're probably do as a part of those core concepts and criteria for QI. Talk about performance measurement here. Moving back to measurement. So in June, only 20% of the patients were getting mammograms. Why is that? We don't. So here's that practices workflow for doing mammograms. And there are some opportunities for them. So first, look at the first thing. They're supposed to be here for their patient doesn't come in for their exam. That's what we've got to look at. And then that's a whole another ball of wax. That's outreach that we're looking at to get those patients in to do that. Next, in this flow, the provider is reviewing the eligibility. That's showing that takes about 5 minutes. Could take more, could take less. Then we may have a specialist to receive a report as we work through this workflow. Had one. Maybe it showed, maybe it had one, you can't see it because of the big yellow there. But now that time as well, who's doing work? The report list doesn't have the report. What if the patient never scheduled or followed that up? How do you know? Who's doing that? Close the loop. And that's what you've seen in a lot of NCQAs. Is how do we close that loop on things? How do we make sure, to the best of our ability, that things are being done? When that patient's being entered is populating the report. So we're at both conferences and one of the regional collaboratives. We've talked about this 4-letter word several times. PDSA, Plan, Do, See, Act. You can see down below, this is a video you can find on YouTube, BA video series, PDSA 101. I can't go here just because there's folks have dialed in and the audio doesn't work. I recommend watching it. It's about 3 minutes long, but we'll talk about it here a little bit. Because there's a lot of opportunities in one process to improve as we look through that last one. For most of you, hopefully this is a refresher on the PDSA, and research and the experts show that it takes at least 3 times of hearing something before it sinks in. So this is probably the 6th or 7th time we've discussed this. So I'm hoping this really sinks in for everybody. And you start utilizing the PDSA cycle. I know some of you use it, and a lot of you talk about using it, but I really want to encourage you to document it. And we have provided a PDSA template. If you need it, reach out to me, reach out to your coach, and we can get that to you. You have access to the curriculum. It's in there on the SharePoint. So, there's many avenues by which we learn about the PDSA cycle and steps through documentation. So let's jump in here. So let's point, identify the issue. Was there 20% of the mammograms, or only 20% of their patients who required mammograms were getting them. So you've got to find out, what can we change in this process? And there were a lot of changes that happened. Hopefully, we'll increase the number of mammograms that are getting completed, not just so we're up to the numbers, but so our patients are getting the right care and the quality care that they need. Make sure we've got a team in place, that we're communicating properly, and then we've got to get data so we can provide feedback. We move into the do. This is you test the ideas that you come up with in the plan. Small. Start with maybe one provider or one site, depending on how many sites you have. Try to do everybody at once. Reiterate that. Start small. We don't have to do all this at one time. It's a process. We work things out. Important to monitor your best. And you do that as well. Do you need any additional training for your staff? Do you need any additional resources? You'll see it could be a new workflow. Well, we decided that our workflow isn't working as it should, so we're changing it. And Dr. Strange, for the next 3 months, we're going to run this PDSA cycle with this group of people. Here's the way we're going to do it. Make sure everybody understands that, has that with them, has any resources available, and then that they're documenting and monitoring that. So when you get in with that, you study, you reflect on, you test. What changed? Did it increase in that 3-month period or that 6-month period, whatever you determined? How did it go? Who was affected? How were they affected? Was it positive, negative? Do we keep this? Was it a thing? Do we modify it? Or do you just scrap it because it didn't work at all and start over? Then you act on those that you saw there. You implement those positive changes. You change carefully. I like that. You got going. You got people bought in. They saw that it was improving, and now it's time for everybody to buy in and become a part of this. And again, you modify things as they go. More people in, you might discover better opportunities, better ways of doing things. You can see there, maybe another PDSA cycle for this, or it's time to do another PDSA cycle for something else. But I do recommend watching that video. You can just put in BMJ PDA video, and it'll come up to our mammogram workflow here. See how we can use the cycle to improve this workflow. At the plan phase, we've identified multiple issues. Let's pick one and decide to change. So let's start at the point where the provider becomes active in the workflow. After 5 minutes reviewing the chart to determine the patient eligibility for mammogram, is this something the provider should be doing as a part of the patient visit? So we change this where the medical assistant or your nursing staff use a quick checklist of eligibility criteria before the patient is seen by the provider. And we go as far as to add a question that sometimes need to be asked of the patient at a mammogram in the last 2 years. Amazing what you might get with just that question, right? And they may do that. The nursing staff do that to know whether a mammogram needs to be ordered. So let's answer the question. What do we think will happen? So we could allow the MA to work at a higher level based on his or her knowledge of training, and it will free up more time for the provider that to vote. The plan phase done. So what do we do? Everybody listen. document. We have to document that. This is a fantastic document that's included in standards that NCQA provides. Quality Measure Improvement Worksheet. Some of you have seen it, some have used it, some haven't. I highly recommend that you use those. So our measure is mammography breast cancer screening. The reason we're doing is only 20% of our eligible patients received a mammogram every 2 years. Your date, your baseline, and the goal they set is 8% for this. Into the duties. So first prepare, you talk to the staff, let everyone know what you're working on, how the process is going to be more efficient. In other words, smoother for the staff and for the patients. And as I said earlier, choose one provider and aim to test that change. Here you have the eligibility criteria available for the staff to review and make sure that they know where to find the information in the chart. Have the provider and the nursing staff on every patient for 1 day. Pick a. Tell everybody what happened. Try it out. That, let's document. So the M reviews the eligibility. The session created on June 15th. Now, so I was right. We did it 1 day. Now, how many does it take for something to become habit? It'll tell you 21 to 30. So it's something that we've got to do. And now we've set an expectation for our staff, right? And stuff, but some expectations we have to do is inspect. We have to inspect our expectations. So we're studying this, and whoever implements this, it's your responsibility to make sure that the staff is doing these things, especially if you want to see change. So completed the test and change. You look at the results. What changed? What were the positives or negatives? What did this was something different than expected? The MA agree it made their jobs easier. Extra steps from the patient was in the room and ready for the provider without any delay. It gave the provider a few more minutes with the patient. There's providers out there, at least one or two, that wouldn't mind napping through a chart for something that could have been answered prior to them getting in the room. MA noticed that when they found a patient who had a mammogram report in the chart, it made sense to go ahead and call the specialist right then to get the results. That they found doing this. Get mammogram reports now fit into the process and does not require additional follow-up at the end of the day or the next. With me. Yep, actions. MA determined that easily call for a report when the specialist as part of the process. And you're like me, you're thinking there's got to be a better way to do that even too. But I guess we're not quite there yet. So finishing up with the phase. So decide to keep the changes to the workflow and to spread it out to all the providers, MAs, through organization. So everyone will be following these new steps by August. This leads to the question, to ensure that the positive results. The staff decided the best thing to do is look at mammogram rates every quarter, but in the meantime, MA who piloted the new process agrees to do 10 chart reviews every week for 6 weeks to make sure the process use the inspection part of it. Keep going. Becomes part of the workflow. It's something you weren't doing before, but things that you were doing before, you're not now, and there's better things that you're doing to make it better for everybody and to get the patient in and out there in an appropriate time with the things that they need. And you're figuring out if they have mammograms done. MA will document the eligibility review, status with the patient when appropriate, called for the mammogram. This way the team would know that the change, or team knows that the change stuck and things didn't slip back to the always. Don't you, just because we've been doing it a certain way for a number of years doesn't mean it's this way, doesn't mean it's the right way, but we don't know until we test it. And here's a perfect way to test it. Document the new workflow by another PDSA to start. What happens after the mammogram is ordered, to ensure the report comes back. So in the meantime, we're going to monitor for 6 weeks, make sure the process doesn't change, and reviewing eligibility, asking the question. The outcome is a quarterly review of those receiving mammogram for 2 years, and it's going to start in October. Right? Celebrate the success, and it's a costly venture. Acknowledge the staff who participated in the test and changing. That's a way to celebrate that. Written note, thank card. I mean, those are simple things. And in fact, because I've seen it, I've seen people that have a handwritten or a thank you card that they received from somebody in their career, could be 2 years ago, could be 20 years ago, stuck at their desk. And it meant a lot to them that that person took the time to recognize them for something they did, especially with a written note. And believe it or not, you go buy blank cards and paper and write a note. I know in this age of technology and all that, we don't think about that, but you can do that, and that goes a long way. And it's expensive, but that you're recognizing them for that. You know, other things you can do. Maybe everybody has a potluck. Maybe you look at challenge that goal again. You know, whatever it may be, but you met your goal. Complete the documentation so there's a record of what happened to you. And whoops, sorry, one step too fast. Complete that documentation, and now you've got your record of what happened. When you thought the time it took to do this, really wasn't that involved. Yes, you had to take time to set aside to look at this process. You had to take the time to, I'm going to go back here a little bit, revamp or work. Some of your time to develop the workflow. You may have anything like this in place. That's the time to do it. Involved in this PCMH transformation, perfect time. And there's templates out there. If you've got PowerPoint, there, you put it together. We're going to send you these slides later. You can use the examples from there. But you can do this with every process you have. And I'm 20-some years in the medical field, but also Air Force, found something very interesting. In the world, they have a checklist for everything. There's a checklist from the maintenance shop to the pilot, and every between. In the control tower, there's a checklist for everything. In the medical field, and here, for some reason, some people think we need a checklist. But it's amazing what we can do with that checklist. A book called The Checklist Manifesto. I believe the title of it. I'll get that to you for sure. I can't remember the author's name, but it's about utilizing checklists in care. We know it's surgery, but it hasn't been for decades. What, maybe 2 2 decades now, 3 at the most. Discovered, though, through a lot of mistakes that shouldn't have happened, that we're looking at our processes. Implementing orders or protocols. I've heard complaints that this is that's medicine or that's cookie cutter medicine. I disagree. If you have standing orders and protocols in place that your staff, they're trained to do, can accomplish prior to the patient being seen by the provider, it gets things taken care of. As you can see here in this example, we move from the provider asking question and looking for the information to the MA. That means the provider can do things the provider can do now, and the MA is doing things the MA should be doing. You know, look at all your staff and get them working the highest of their capabilities, the highest of their licensure, the highest of their training that they've had, and put these into place. You will see change in the way things are done in your practices, in organization. You'll see a change in patients. You'll see a big change. Will you go from 20 to 80%? Oh, it's possible. Will you go from 20 to 90%? That will as well. But you can make that workflow that much better. Do a thing at a time, one at a time, and take these steps. And to come a RISE, NCQA, PCMH, you have these things. So it's accept it if you're not doing it and implement it. And if you've been doing it and you've already been recognized, it's time to go back and look at what you've already got in place to fit the right thing, to see if it's working, or to see if there's a way to that and refine it even more. I did not intentionally mean to fly through there, but I was excited about that. So that brings us to the end of this presentation as far as these items go, and look at and measuring performance and process improvement, especially specifically in regards to 2017 NCQA PCMH. Now, I'm going to turn things over to you. So if you have any questions, comments, suggestions, this is a great time for you to do that. Let me. All right. I noted that there may have been an update with something on one of the slides, so thank you for that. It's funny you do slides and then there's always an update. I appreciate that. Some of the slides will be available. Yes, Meredith will make the slides available on TennCare's website, and she'll talk about that in just a few moments here. And if you need any type of document, something to this effect, reach out to your coach. Or if you have access, which you if you have access into the SharePoint where the curriculum is, this information is in there, and then we're adding things and this items as we come across them. Any comments, questions anybody have, please put those in the chat box. We do have some extra time. I'll give a few more seconds here. I won't belabor this anymore. Our next session will be in September. It's going to be one of the last 2 weeks of September. We've got a few things going on, and we're trying not to overwhelm all involved in this, the coaches and the practices. We have the August collaboratives coming up. You've seen the emails for those. Please register for those on community sources. One of the things that we wanted to talk about in there was transportation, but we couldn't get the right players in place for that. So we see this coming out soon. We're dates down, but in September, we'll also have another collaborative in all regions, transportation and access. And we'll actually have some folks in there from the MCOs who can speak to transit for TennCare and Medicaid patients. I'm going to come back here. Any more questions? So with that, I will return control of the session back to Meredith for any final remarks. Meredith.
And thank you for this awesome presentation. I just mentioned a lot of different areas in which you can find these resources and examples. So if you don't have access to the PCMH curriculum on SharePoint, or if you're not sure where to find the webinar and recordings and slide decks where they're posted, please feel free to shoot me an email. I'm going to put my email in the chat box, and we can get you connected to the right places and to the right people to get access to those documents. Also, we'll be posting the recording for this webinar as well as the slides later to the PCMH website, as Rick mentioned. So I will send out a little reminder when those are posted if you want to reference this later or if someone from your organization was not able to attend. And always, if you come up with any questions or any follow-up items after today's webinar, feel free to reach out to myself or Rick Warren to share those pieces of feedback. With that, I want to thank you all for taking the time out to join us for today's webinar, and have a great weekend.
Appreciate your time.